rather than presenting in telling about the mechanism of action and its pH levels and all, but I will be presenting in a different perspective. Uh, that is how these drugs perform in various challenging situations and in different comorbidities. So these are the conventional systemic drugs which we use in day to day, and I especially you also use this isotretinoin, which works pretty well, and especially in case of acne and psoriasis. These are the recently one small molecules which have come up. That is apremilast and tofacitinib. Coming to the biologicals, these are the TNF alpha inhibitors, the etanercept, adalimumab and infliximab. Secukinumab, which is an interleukin 17 inhibitor. The upcoming ones are isakizumab, golimumab and pesolimumab. So let's compare the drugs in different scenarios, or I would like to say challenges. First, moving on to inflammatory bowel disease and coexisting psoriasis. So the symptoms of IBD, basically IBD consists of Crohn's disease and ulcerative colitis. Both are chronic diseases, and they present with symptoms of diarrhea, persistent diarrhea, I would say, fatigue, abdominal pain and cramps, blood in the stools, reduced appetite, unintended weight loss. And there's an overlap in the pathophysiology. Because of the overlap in pathophysiology and genetic background, IBD and psoriasis patients, they have at least threefold risk of developing Crohn's. So, coming to the conventional drug, we often use methotrexate. It is shown to have very limited efficacy in Crohn's and still very less efficacy in ulcerative colitis. And it is often found that cyclosporine is often given in steroid refractory ulcerative colitis as well as in active ulcerative colitis. Acitretin, it is recommended to give in psoriasiform lesions with IBD, and it is found to be preferred in as an adjunct in paradoxical psoriasis. So what is paradoxical psoriasis? It is nothing but development of new psoriasiform like lesions when the patient is on anti-TNF alpha therapy, despite there is a response. So in that cases, acitretin can be added. Limab, as well as the interleukin 12 and 23 inhibitors, there is ustekinumab, but still not yet available in India. A point to note here is the etanercept is not at all effective. And another important point to note is interleukin 17 inhibitors, secukinumab, should be avoided. I remember a case, I think, going on to depression. Not just depression, there are other psychiatric symptoms which coexist with psoriasis, like mood disorders, personality changes, and all. And monitor for symptoms of depression, because these drugs were found to increase the risk of depression. So try to use the alternatives to apremilast as well as acitretin. So all the biologicals are preferred in depression and coexisting with psoriasis, and it is found that they improve psoriatic manifestations, also they improve the symptoms of depression. And always biologicals show more response when compared to conventional therapy in these cases. Next, moving on to diabetes, I think we've already discussed in the morning session, but still. So both diabetes and psoriasis, they share a common genetic background, insulin resistance and unhealthy lifestyle. And they have both type 2 diabetes mellitus, obesity, non-alcoholic fatty liver disease and metabolic syndrome. So what are the effect of drugs on diabetes mellitus and psoriasis patients? So methotrexate short term, no effect, but to be cautioned, long term, whenever we give methotrexate for long term, just be aware that there is hepatotoxicity when it is crossed 1.5 gram overall dose. So cyclosporine, it is found that it increases de novo diabetes in many of the cases, especially when it is given for transplant cases. Acitretin, apremilast are preferred. in that cases. Now all the biologicals here which are available can be given. Next, heart disease and associated with cardiovascular risk factors associated with metabolic syndrome. This is the carotid intima media thickness and helps in the cardioprotective, as well as apremilast also is found to be cardioprotective. So a caution with cyclosporin because it can worsen the hypertension. Similarly with acitretin because it causes dyslipidemia. So biologicals are preferred and can be given in case of heart disease and psoriasis. Next, heart failure. So heart failure patients usually present with symptoms like breathlessness, ankle swelling and fatigue. And they show signs like elevated jugular venous pressure, pulmonary crackles and peripheral edema. It can be caused by structural and arterial hypertension, atrial fibrillation, ventricular heart disease and cardiomyopathy. Now the New York Heart Association has classified this into 4 classes. Class 1 with no symptoms and no limitation in ordinary physical activity. Example like shortness of breath while walking only and climbing stairs. Class 2 with mild symptoms, mild shortness of breath or angina and slight limitation during the ordinary activity. Class 3 is marked limitation in activity, and the example like walking short distance of 20 to 100 meters. They are only comfortable at rest. In class 4, it's severe limitation. They experience symptoms even while they are at rest. So all the conventional drugs like methotrexate, acitretin, apremilast can be given in these cases. Caution with cyclosporin as it may increase the blood pressure. Here an important point to note is the adalimumab and infliximab. You have to avoid them in class 3 and class 4 because it can worsen heart failure, but you can give it in with caution in class 1 and 2. Etanercept similarly you can try to avoid it. Interleukin 17 inhibitors can be given, and also found that it improves the endothelial function in the blood vessels, and it is cardioprotective. Next, moving on to renal failure. Psoriasis patients, they have increased risk of developing chronic kidney disease, and this risk is found to increase with the severity and duration of psoriasis independent of the risk factors. Independent of these risk factors include diabetes, hypertension, cardiovascular disease, drugs which impair the kidney function. So while treating this renal failure patients with psoriasis, methotrexate when given, so always monitors the serum creatinine levels, creatinine clearance levels as well as the blood pressure. If creatinine clearance is between 61 to 80, reduce the methotrexate dose to 25%. If it is between 50 to 60, reduce it to 30%. And if it is within 10 to 50, reduce the dose up to 80%. Below 10 creatinine clearance, avoid it. Similarly, acitretin, it is widely used. It also has been given in case of cancer prophylaxis in patients. And apremilast, as I think always Dr. Vikram sir also told in his quiz, reduce the dose whenever the creatinine clearance is below 30. Make it half. Tofacitinib, similarly, it can be given, and similarly, creatinine clearance, if it is below 30, reduce it to half the dose. Cyclosporin should be avoided as it is nephrotoxic. And both the TNF alpha inhibitors and interleukin 17 as well as interleukin 12 by 23 inhibitors can also be given at all stages of the kidney disease. So neurological diseases with psoriasis, it can be stroke, multiple sclerosis, seizure, migraine, Parkinson's, Guillain-Barré syndrome as well as myasthenia gravis. They are all reported in neurological diseases in case of psoriasis. So cyclosporin has a lower risk while giving in neurological diseases. It is found that in transplant patients, when cyclosporin was given, 14% of them have showed neurotoxic, neurotoxicity. And because the calcineurin is also a component of the neural tissue, it was showing neurotoxicity. And also another way where because it decreases the magnesium levels, it is found to be neurotoxic. Methotrexate also has a low risk. Rarely it is neurotoxic, but mostly it is found with when given in intrathecal administration. Here fumarates are the preferred one, that is dimethyl fumarate, because they are often given for neurological disease like multiple sclerosis. So this is the best drug to give when coexisting psoriasis with neurological disease. So the biologicals in neurological try to avoid TNF alpha inhibitors because they worsen the neurotoxicity. And interleukin 17 inhibitors can be given, but it shows very limited data as of now. Next is viral hepatitis. So both psoriasis and viral hepatitis, they share a common characteristic of chronic inflammation and immune response. It has been hypothesized that the hepatitis B virus may trigger or even aggravate psoriasis. In one study by Guadagnino et al., it showed higher risk of HBV infection in patients with chronic psoriasis or eczema. The study was done in Naples, Italy. So at least 10% of them show psoriasis patients compared to the 4% of general population had HBV infection. So the prevalence, it was found in that area that 4 to 18% in general Italian population, indicating a HBV rich environment in that area. Therefore, they considered that virus could easily penetrate through the micro lesions of the skin affected by psoriasis. So, while in hepatitis B reactivation risk is more with the biologicals. So, there's caution for that. Otherwise, all the conventional drugs, there's not much risk with them. So, for hepatitis B, screen the HBsAg, anti-HBsAg, anti-HBcAg also. For hepatitis C, anti-HBc. So it is recommended in few studies that they should be done before giving even the cyclosporine methotrexate also, which we often do, do not do, but we do it for biologicals. So acitretin, apremilast as well as methotrexate, they have there is a low risk for HBV reactivation with them. So always monitor LFT as well as the HBV DNA levels every 3 months. And there is a high risk with the tofacitinib, cyclosporine as well as TNF alpha inhibitors, but not much conclusive data was found with interleukin 17 inhibitors. So even antiviral therapy should be continued for 6 to 12 months after stopping immunosuppression. Coming to tuberculosis and psoriasis, screening for the latent tuberculosis infection should be performed in all patients of psoriasis planned for systemic therapy. So timely detection of this latent tuberculosis infection, it helps in prevention of active tuberculosis in patients who are on immunosuppressive therapy. And this is another study wherein the main aim was to find the prevalence of latent tuberculosis infection with psoriasis while they were planning for systemic therapy. It was found that MAN2 was positive in at least 31.4% patients, and chest X-ray was abnormal in at least 5% of the patients, and remaining them it was normal. The features of active tuberculosis were seen in one patient, and it was reported as an old infective pathology. CT chest and abdomen was advised in all the patients who had a positive MAN2 test. And at least 81% of patients underwent CT scan of them, and positive findings were seen in 30% of the patients. So these patients and the important thing is these patients did not have any clinical features of active tuberculosis like fever, night sweats, cough, and weight loss. So overall 30% patients were diagnosed as latent tuberculosis, and they were treated with isoniazid and rifampicin for 3 months. So always take a history of tuberculosis, the symptoms, and then go for a chest X-ray if needed. MAN2 and TB gold quantiferon tests should also be done. So these are some of the therapeutic regimens. If you are giving NH alone, give it for 6 to 9 months at 300 milligram. Rifampicillin alone, 3 to 4 months, 600 milligrams. If combination of both of them, you give it for 3 to 4 months. This is the recommended regimen. Next, the drugs. There is no risk of reactivation with these drugs, with reactivation of tuberculosis with these drugs. But there is a slight risk with methotrexate, cyclosporin, as well as interleukin 17 inhibitors, and a high risk with tofacitinib as well as TNF alpha inhibitors. Next, pregnancy and psoriasis. In a study of this systematic review of observational studies, it was found that 4 of the 9 studies reported increased risk of adverse fetal outcome, spontaneous abortion, cesarean delivery, low birth weight, large gestational age in psoriasis patients, but the study results were inconsistent. So, as you all know, pregnancy improves in at least 40 to 60% patients. Psoriasis improves, and psoriasis can worsen in 10 to 20% of the pregnancy cases. It will be stable in the remainder months, and if at all it improves, it will improvement will be very dramatic. And in a study, it was found that women with more than 10% of the body surface area involvement of psoriasis, mean reduction was between 10 to 30. Between 10 to 30 weeks was 84%. So you always avoid methotrexate while in pregnancy. Lactation is contraindicated. Another thing here is you have to stop methotrexate when you are giving for men before they plan for conception. Avoid acetretin in women, and it is always better to tell the patient to take protection while even after post conception for men, even though results are inconsistent that it can cause adverse pregnancy outcomes in men, but it is better to tell them to be protected while undergoing for sexual exposure even after post conception. So avoid TNF alpha inhibitors, interleukin 17 inhibitors in both pregnancy and psoriasis. Cyclosporin can be given, but if at all if it has to be given, start from minimum dose and gradually increase. Monitor the BP, renal function test. It can be given in lactation. So this is an overview of the minimum time required between the stop of the treatment and the conception. For infliximab, it is 6 months. Adalimumab, 5 months. Etanercept 3 weeks. For secukinumab, it is 20 weeks. Even though information is not provided in SMPC for apremilast, it said that it should be 28 days, the minimum time to stop the treatment before conception. Next, HIV and psoriasis. So it is found that in HIV infected patients there is higher incidence of psoriasis, and it presents with atypical presentation and the exuberant clinical features, and it is recalcitrant to the conventional treatment. So in this, the first line preferred drugs are the acetretin, apremilast. With tofacitinib, they have limited results. Avoid the methotrexate and cyclosporin, but both the biologicals available in India can be given. So coming to combination of the systemic drugs. So when they can be given for moderate to severe psoriasis, because it gives better results and it helps in allowing for lower doses of both the medications and has a fewer side effects. So you can options like systemic plus topical can be given, systemic plus phototherapy, as well as you can combine both systemic drugs. So methotrexate with biologicals, there is an advantage here that it helps in inhibition of the anti-drug antibodies. So whenever the biologicals are inefficient, and you can add methotrexate. Next is acetretin plus biologicals, especially as I said previously, it is used as an adjunct in paradoxical psoriasis. Methotrexate plus cyclosporin, both of them increase the blood levels of each drug. So it gives a rapid control of the disease. Methotrexate plus retinoids, it is shown that not much increase in liver toxicity is found, so it exhibits a higher effectiveness. In some studies, it was found that acitretin plus cyclosporine, this combination can be given as it reduces the cyclosporine-induced cancers and precancers. This is in one of the study I found that here what important point is note that avoid cyclosporine when given with combination of do not give it combination with biologicals. It's not beneficial, not recommended also. Sequential therapy. It involves the drugs in a deliberate sequence to maximize the rate of initial improvement as well as the minimizing the long-term toxicity to improve the outcome. So it entails 3 phases: clearing phase, transition phase, maintenance phase. So first to clear the disease, then transition to other drug, and then maintaining it. So options, you can first initially start with cyclosporine, then acitretin, and then phototherapy. Acitretin, later topicals can be given. Methotrexate followed by acitretin. Rotational therapy, to minimize the risk of, it is given to minimize the risk of cumulative toxicity. So herein the drugs are rotated once in every 2 to 3 years, then switch on to other drug. It helps in increasing the options here include cyclosporine, methotrexate, PUVA by NBUB, acitretin, as well as biologicals. So no washout period is needed to switch to other biologicals. Usually if one drug has failed, there is no washout period needed. You can directly switch on to the other drug. So overall take home points: no perfect drug is available which suits for all conditions associated with psoriasis. For acitretin is always preferred for paradoxical psoriasis and in diabetes mellitus and pustular psoriasis as well. Cyclosporine preferred in pregnancy, lactation. Start from a low dose. Avoid combination with biologicals. Methotrexate is the preferred when anti-drug antibodies are developed when treatment with anti-TNF alpha therapy. Tofacitinib, moderate to severe psoriasis but with limited efficacy. It is found that we have to give it double the dose, which is 10 mg BD, which is usually the 5 mg BD dose is approved for psoriasis. And higher doses showed better efficacy but associated with more adverse events. Apremilast is overall safe. Exceptions: do not give it in depression. Works best for scalp psoriasis, palmoplantar psoriasis, and mild psoriasis. TNF alpha inhibitors, they are the first drugs to be given in inflammatory bowel disease. Avoid interleukin 17 inhibitors, that is secukinumab, in inflammatory bowel disease. Avoid combination of cyclosporine with biologicals. Thank you for your patient listening.